Welcome to Depression for the Caregiver, presented to you by the Neuropsychiatric Nursing Special Interest Group of GAPNA. So in this module, the term persons living with dementia will be used to emphasize that dementia is a diagnosis and does not define an individual. Dementia and depression are symptoms that are highly stigmatized in the disease process of dementia. The term person living with dementia is used to promote positive language and a more person-centered approach. The purpose of this module is to discuss the neuropsychiatric syndrome of depression. Depression is a mood order that frequently occurs in persons living with dementia. Persons living with dementia are twice as likely to experience depression. More men living with dementia and disability have depression than women. 25% of persons living with mild dementia have a diagnosis of dementia. The risk for depression varies by the type of dementia. Persons living with Lewy body dementia are the most at risk for depression. Depression commonly occurs in vascular dementia. Depression frequently presents in mild cognitive impairment in the early stages of Alzheimer's dementia and may worsen over time. Depression is a risk factor for Alzheimer's dementia, especially for older adults with mild cognitive impairment and active depression, meaning a known diagnosis of depression that's being treated. The hippocampus is a very small organ in the brain that is associated with thinking and what we in healthcare use the term cognition. When MRI imaging was studied over a 2-year interval in adults 60 years and older without dementia, hippocampal atrophy or swelling on images was associated with how severe a person's depression was. Conclusions from that research indicated that further studies are needed on the swelling and atrophy of the hippocampal center and will help us maybe in the future diagnosing dementias earlier. So what is depression? Depressed mood or loss of interest in pleasurable activities almost every day are the primary indicators of depression, along with decreased concentration, changes in weight, either gain or lose, loss of energy, feelings of worthlessness or inappropriate guilt, slowing of thought and physical movement, hypersomnia, meaning all they want to do is sleep, or insomnia, which is not being able to sleep, as well as recurrent thoughts of death with or without a plan. So depression occurs with multiple chronic illnesses. There is an overlap between dementia, depression, and certain chronic illnesses. Diagnoses can be insidious. The diagnosis of dementia becomes clearer when depression is recognized and appropriately treated. Depression with psychotic features adds another layer of complexity in the diagnosis of depression and dementia. Persons living with dementia typically do not present with sadness, which most people correlate to depression. More subtle symptoms such as sleep disturbance, fatigue, complaints of pain, or anorexia are more common symptoms of depression associated with Alzheimer's disease. So caregivers are truly in a unique position to recognize triggers for depression. Triggers for symptoms of depression are individual to every single person, regardless of whether they have a dementia or not. Loneliness can contribute to depression. We know through the COVID-19 pandemic that staying at home and being socially isolated has also contributed to depression. Your loved one may mourn loss of independence. Persons with dementia may not be able to communicate emotional distress, and this may contribute to symptoms of depression as well. So early treatment is very important to prevent worsening of symptoms. Suicide is the most severe but preventable outcome of depression. If a loved one starts giving away items or expresses thoughts of suicide, you need to get them for immediate medical attention and most likely inpatient evaluation. That is needed because there needs to be an accurate diagnosis made, especially if they are contemplating suicide or have a plan. And then once they're discharged from the hospital, need to be followed very closely on an outpatient basis. So if a loved one gives away items or expresses thoughts of suicide, as I said, immediate medical attention and inpatient evaluation is needed. Follow-up with psychiatry early in the diagnosis of dementia is one prevention strategy, especially when there is a history of depression in the family or any previous inpatient psychiatric evaluations. Removing firearms from the home and environment is also very important. A loved one who experiences anorexia requires immediate and early intervention. Supportive treatment with non-pharmacological and sometimes pharmacologic interventions are used to stimulate appetite. Music, art, and pet therapy are extremely useful in non-pharmacologic treatment of depression. Increasing social networks is very important. Treatment for sleep disturbances is very important. However, treating with sedative, hypnotic medications is associated with many adverse side effects, including worsening ability to think or our cognition. Eliminating caffeine, regular bedtime, and exercise can be helpful to eliminate symptoms of depression. Your loved one may be prescribed an antidepressant. Medications commonly prescribed include selective serotonin reuptake inhibitors, or SSRIs. These are prescribed for mild to moderate depression. Depression is a risk factor for dementia. Symptoms of depression are atypical, and persons living with dementia may not verbally express emotional distress. Symptoms of depression are often overlooked in the general population. There are many overlapping symptoms of chronic illness and dementia that may overshadow symptoms of depression. Early detection, early treatment, early management of depression improves quality of life for both persons living with dementia and their caregivers. Once again, caregivers who want to know more about neuropsychiatric symptoms of dementia are encouraged to participate in the Dementia and Neuropsychiatric Syndrome series. Thank you very much.